All right, I need to just get this away. Perfect. So as you can see from this first slide, this is where I work. This is La Nostra Familia. For those of you who know a little bit of French, you might have guessed what it means. It means our family. And this little dot here is where I am and I live and I work. This is the boot-shaped Italy that you might have recognized already. Okay. All right, what are we going to talk about? I have 40 minutes. That's quite a lot of time. And so I really want to cover the basics of intracranial pressure. Some of you might really think this is too basic, but I think if we review the basics, it would actually help us understand different real life cases, which I will show you in a bit. Some of these cases might not be pertinent to the type of patients you have in Africa, but I think the concepts are global. And then we'll talk about neurofluids, which, as you just heard, is my baby. Let's start with the first case. Now, this is a 2.5-year-old kid with autism. Okay, he was in our hospital and got an MR. So just take a minute to look at these images, right? You have an axial flare, you have a coronal flare image, you have a sagittal T1, and you have a high-res T2 weighted image looking at the eyes. Do you see anything? Just, anything big. Don't look at anything very, very small. But do you think the ventricles are, have the right size, morphology? Do you think the sulci are looking good? The parenchyma, is there anything that, shouts out, like kind of stares at you and say, this is wrong? You look at the cisternal spaces. What would be your diagnosis here, if there is any? Again, this is a patient with autism. We're talking about hypertension. We're not looking at malformations, okay? So I'll tell you at the end of the lecture what the diagnosis is and what the findings are. So you'll have to bear with me and stay with me right till the end. We'll start with the MONRO-KELLIE doctrine. I'm just going to remove this, okay. We'll start with the MONRO-KELLIE doctrine. Now, how many of you have heard about this doctrine? I know you can't speak up, but just think about in your brains, in your minds, yes or no. And if you know, here is the doctrine. It basically says that the intracranial pressure must remain constant at all times. Okay, so at whatever time of the day, it must remain constant. Now, what is intracranial pressure and why should it remain constant? So you know about this little chart, this little graph here, that there is a range of arterial pressure. Mind you, this is not intracranial, arterial pressure, within which the brain, the cerebral vessels, auto-regulate themselves such that the overall arterial pressure, the mean arterial pressure, never changes. It remains constant in this range. This is important. The arterial pressure is important because it directly influences the perfusion pressure. The perfusion pressure is absolutely important because it is what determines the flow of fluids, flow of oxygen, entry of glucose, and removal of waste. And the perfusion pressure depends not only on the arterial pressure, but also on the intracranial pressure. And this will become simpler as we go forward. So very simply put, the perfusion pressure, which is fundamental for the health of neurons and glial tissue, is equal to the mean arterial pressure minus ICP. And the mean arterial pressure, as you know, the resistance to flow is dependent on R to the fourth power of the radius of the cell. So basically the vessel will dilate or will contract according to what the pressure is in the brain. And I think this graph actually sums it all up. You have a mean arterial pressure of the blood vessels that goes into the skull, into the brain. and it goes out. This is the perfusion pressure right here, and then there is outflow. If the ICP within the skull, which you know is rigid and cannot expand in the adult life, if the ICP increases, there is going to be collapse of the veins. There's going to be a shift in the volumes of different areas or different components within the skull. All right? What I mean by that is the following. What do we have inside the brain? What forms the intracranial volume? Brain tissue, for sure. We have blood in the brain, and we have CSF. Anything else? Let's break this down. This red circle is the skull. Now, the brain tissue is made up of gray matter, white matter, and some fluid. We will call it interstitial fluid, because it's got the dry cellular component, plus it has an interstitium, which is full of fluid. And so you can imagine that all these three components have different chemical and physical properties of compression or elasticity. Very important to understand pressure. This is the most important part in the entire lecture. Blood can be subdivided into a venous compartment and in an arterial compartment. The venous blood is more than the amount of arterial blood in the brain. 70% of the total blood in the brain is venous. Very important, because venous vessels are collapsible, arterial vessels are not. Venous vessels are more variable, arteries are fixed. CSF has, again, two components, right? Two compartments. One is in the subarachnoid space, and the other is in the intraventricular system. Again, there is a difference. All of these compartments are different in their physical properties. And you can now visualize if there is a tumor or anything in any of these compartments, because the skull is rigid, will occupy or push away the other spaces around it. Okay, so now you get the direct and indirect signs. So when you're looking at your MR images, you're not looking at the tumor only, you're looking at all the spaces and all the compartments in the brain. Now, recently, they've also found out that the skull itself can be remodeled in the adult brain. So they can be scalloping, you know, just to, if there is increase in volume, the bone can also be remodeled, and that is an important indirect marker as well, to understand if there is volume increasing in the brain, and that's causing the hypertension. And very recently, we also have discovered that there are lymphatics in the brain, which is a completely different chapter, and we will not talk about it. Probably we'll just kind of hint on them. So as I said, when you look at your MR images, please look at every different compartment in the brain. You're looking at arteries, you're looking at veins, you're looking at the jugular veins, you're looking at the brain parenchyma, ventricular system, etc. This is an image which is really, really interesting and very, very, and describes very well the concept of neurofluids. It's a coronal drawing on your left here. And this is a T2 coronal image, nothing fancy. It's a 1.5 Tesla image, 4 millimeter thick. So you're not looking at anything, you know, that you'll not be able to see in your scanners. It's pretty easy. And what you're seeing here is basically this. Again, some visualizing here to do. You have these arteries, the heart pumps, right? It has it goes into systole and pumps out. There's a stroke output. There is stroke volume, pumps quantity of blood that enters the arterioles. You might, is talking? Okay, so arterioles basically dilate right here. And when they dilate, what happens? There is an increase in pressure because there is an increase in volume, increase in pressure in the subarachnoid space. So in the normal subject, without disease, what will happen is CSF is going to be displaced out It needs to shift because all the arteries have now dilated. So they push away the CSF, and the first thing that happens is that CSF moves from the brain down to the spine. So that's the first moment when the increase in volume, so increase in pressure reduces the pressure by the CSF that goes into the spine. The other thing that happens in the subarachnoid space is the compression of these cortical veins, and therefore now there is a pressure gradient, and the venous blood is going to move from the cortical veins to the venous sinus. So a lot is happening right here during one cardiac cycle. And so any disease right here can affect pressure and perfusion. Think about meningitis very simply, right? So this is one of the things that I think is very important to understand. And in fact, I'll show this to you as a video. As the heart goes into systole, you can see that the arterial blood inside the skull increases the volume. The CSF goes down outside the ventricles, and the spinal CSF volume increases. And as a last step, we have venous outflow. So you can see how the neurofluids are together in a harmonious, synchronous manner, working to reduce the temporary increase in pressure and reduce volume. Okay. Now, basic, this everybody knows about this, right? The CFs of circulation, the classical model. CSF is produced in the choroid plexi. It moves out down to the aqueduct of Sylvius. It goes out to the subarachnoid space, and part of it goes to the spinal fluid. It's a one-way flow. It's directional, unidirectional, and so far, so good. In fact, what we see in our brain, in our daily images is that if there is a tumor, very simply, this is a meningioma. If it's big enough, it will start to displace the brain parenchyma. Nothing, we see this all the time. There is going to be a lot of edema because there is pressure. There is pressure on the brain parenchyma. There is fluids start to stagnate. They cannot move out. They cannot drain. And so there is an increase in interstitial edema. We call it vasogenic edema. What else can you see here? If you look at the eyes, the optic nerves, you will start to appreciate with some of the knowledge, some of the things that I've just discussed, that there is an increase in the CSF spaces. The subarachnoid space right here is increased. So you have the optic sheath that is enlarged, and you can also see protrusion of the optic disc. And that is because there is a point of, it just gives, there is no hard structure here. And so now you can see how the optic nerve is being pushed. So as many times these patients will just come because they have visual loss, for example, right? So see how a tumor can affect optic sheaths. The other thing that is very interesting, it needs a little bit of experience, is the engorgement of the venous vessels as well. So there are a lot of things that are happening. The brain as a whole is reacting to this tumor. So I think it's very important to keep reading, looking at the indirect signs, the collateral signs, if you will. You see the meningioma, you're like, great, I saw a meningioma, I made the diagnosis. It's all wonderful, but you might want to understand that most of the symptoms of the patients are coming from the dysfunctional brain parenchyma, the optic protrusion, nerve protrusion, etc. This is a tumor medulloblastoma in a kid in the fourth ventricle. Again, very easy, right? You see this obstructive hydrocephalus, you see this great mass, you go all the lengths in measuring the tumor, etc., which is important. But it's also important to understand how the brain is actually reacting to this tumor, how the brain as a whole. And these are all causes of hypertension. And these are patients that come with headache. That is the reason why the patient has headache, right? And that is because the pressure is too high. And that is right there, your intracranial pressure. In these patients, we cannot measure it with MR, will have a reduction in perfusion. Well, we can in MR using perfusion-weighted imaging, but we don't do it all the time. But there is going to be a reduction in perfusion. There might be areas of ischemia or stagnant, reduced perfusion in brain parenchyma, and therefore reduction in executive functions as well. You will see CSF leak around the ependymal wall of the ventricles. If they cannot drain, there is obstructive hydrocephalus. If they cannot drain properly, then some of this will leak out through the ependyma as well. And we know that even in normal subjects, there is a pathway with CSF to actually connect with the ISF, interstitial fluid, in the parenchyma. Okay, so this is leak plus stagnation of CSF. This is a patient with chronic meningitis. And after 10 or 11 years of meningitis, this patient continues to suffer headaches. So meningitis has been treated, but then you have headaches. And so what we see here is adhesion of the aqueduct of Sylvius. So basically this area is blocked, right? And so CSF can no more flow down the ventricles, down to the fourth ventricle and to the spine. And so the ventricles are enlarged, the brain parenchyma is squished. So this is a case of, yes, ventriculomegaly, yes, obstructive hydrocephalus, but also hypertension, intracranial hypertension, which will have its consequences. If you remember the formula, CPP, perfusion pressure, is equal to mean arterial pressure minus ICP, you can now understand how many other factors are affected. This patient may have memory loss, this patient may have other cognitive dysfunction, neurological findings, symptoms, which are related to the parenchyma that is not perfused well. And so in these cases, you already know this, obviously, the surgeon just goes in and tries to open up a little pathway for the CSF to flow out, because the production, of course, continues. Okay, so this is what we know, but there is more to this. Okay, this is not the only way of producing CSF in the brain. These are details that just have come out in the past 10 years. We kind of not really know about this. Are there any questions, by the way? Just to give us a little pause, quick one. How would you differentiate, I know. How would you differentiate transependymal leak from periventricular white matter changes in the early phase? It's absolutely not easy, but then again, this is a matter of, identifying all the indirect signs. Now you're looking at ventricles, you're looking at the morphology of ventricles. Are they rounded off, right? You're also correlating with neurological symptoms, right? How much is the white matter? What is the morphology of the white matter hyperintensity? We'll talk more about this as we keep going forward. You'll hear more about white matter hyperintensities. So very quickly here, the CSF is also produced at the level of the blood-brain barrier. So basically the exchange of water here, and at the level of the endothelium, which is the wall of the arteries, there is a movement of water through stalling forces. You know about this, osmotic forces. And the water, the water that leaks into the interstitium forms the interstitial fluid. And that is basically, not all of this goes back into the venous blood. Part of it intermingles with the CSF, with the ISF, and is important for the hydration of the brain and for the movement of neurotransmitters, neurovacuoles, neurovesicles, peptides, movement of waste products, etc. And this is only one slide because it's a very difficult concept. Remember that the CSF in the subarachnoid space actually enters the perivascular space. So this is it's not just goes into the arachnoid granulation and out, but it also recirculates and goes back into the brain parenchyma around the perivascular spaces. And this is now becoming a big phenomenon. This is part of the neurofluid story, where all of this fluid is now important for the movement of waste products. So going back to CSF absorption, so we understand that it's arachnoid granulations, but CSF is also being absorbed at the level of meningeal lymphatics, at the level of the cribriform plate, nasal lymphatics, etc. So there is more to what our textbooks currently are telling us. Now look at this case. right? 72-year-old female with progressive cognitive symptoms. And the only thing that comes out from her blood work is anemia. Look at these images, right? Do you think ventricles are enlarged? Maybe. We don't have a parameter for ventriculomegaly, but maybe they're enlarged. You can see some white dots right here, all of this hyperintensity. So look at this. This has a star-like margin. So I fear that this is a leak, all right? And not just a white matter hyperintensity, which is gliosis. Something definite. This is more likely gliosis, but this probably is a leak. But again, as you see, we are talking conditional. We're not very sure. So we're looking at this, do the sagittals. Doesn't really look like hydrocephalus, INPH, those kind of diseases. Then we do a GRE, the gradient, or the SWI, whatever sequence you have to look at blood. And this looks like superficial cirrhosis. So there's blood definitely in the ventricles, and it's also in the sulci. So this patient is anemic, most likely because she's bleeding in her brain. Okay. Now, why she's bleeding is for the neurologist to understand. But in the MRI, these are our findings. And when we discuss the case with neurologists, we can tell them, listen, I see this, I see that, I see these. This is not a good shape of a sulci. Right, kind of cystic, dirty. So I went ahead and checked, with these T2 weighted, heavily T2 weighted images, and this is not hyperintense as the CSF. So there is blood right here. So probably this patient has obstructive hydrocephalus. You can see the rounded ventricles. Again, this is a case of hypertension. This is most likely hypertension that is also giving her cognitive symptoms. This is just another case, and I had no clue what this patient had. This is a 70-some-year-old male, and he, again, not walking properly. He has, he had paraparesis. So I look at this. I have no history. I don't understand what he has exactly. So without all of that, I just didn't like this little lobe. This is not tumor, but it's full of something. Right. I unfortunately don't have other images, but if you see properly, there are some black structures, dots, etc. So this was actually a malformation, arterial malformation with some stagnant fluid around. And in fact, you can see that this ISF, this is a perfusion weighted image, and you can see that there is stagnation of gadolinium in this area. Okay, there is increased volume, there's an increased mean transit time. What I'm trying to say with this case is that that there can be sometimes these changes that need to be picked up and evaluated in terms of pressure changes, volume changes, and how the brain reacts to it. Let's talk about another entity which is very dear to me. I'm just going to take a look at the time. Probably in about 15 minutes, I'll stop. Godwin? So let's talk about idiopathic intracranial hypertension. I'd really like to know how many of you have seen a case of idiopathic intracranial hypertension, but I fear I cannot get this response from you right now. It's a pretty rare disease. And as you know, idiopathic basically means we don't know why the patient has what he has. So idiopathic is that term which basically says we have no clue what the cause of the Parkinson's disease is, of intracranial hypertension, or whatever disease. So you will have heard about this IIH as pseudotumor cerebri or benign hydrocephalus. Please don't call it benign because it causes visual loss and blindness. So the term benign has been dropped off. Pseudotumor cerebri is great, but the best way of identifying this case that I'm going to show you is idiopathic intracranial hypertension. 34-year-old female, 2 years of I don't know how many MRIs, obese. She has several headaches. They're treatment resistant, progressive visual loss. And this is the patient that comes to me to do an MRI. And I'm perplexed. Why is she doing, I don't know, was it the third or the fourth time she was doing an MRI? And these are just some images of this patient. I look at this MRI, I'm like, you don't have anything. I mean, the ventricles are fine. Great sulci, you have a good brain parenchyma. I can't see tumors, I can't see edema, I can't see white matter hyperintensities. The skull looks great. The sagittal, probably there are a lot of cisternal spaces, a little bit big, but you know what's normal. And I'm looking at the hypophysis. It probably is a partial empty cella. You know, going back and forth. I'm not seeing anything. Then it hits me. Visual loss, 34-year-old, childbearing age, obese. So that's your, and that's when I gave gadolinium. Now I'm looking at the veins. Now look, you go back to your MR, your reporting tomorrow, and you look at the veins. Go look at your veins. You will, so this is an engorged vein. I mean, why would the veins be engorged? Right? But I'm still not understanding. But because I had studied IIH, I had seen another case, I went ahead and did the optic nerve sheath study. And I look at this and I'm like, oh, visual loss, headaches, obese, female. This might be idiopathic hypertension. So when you're looking at the optic nerve sheath, you can see that from the entire length, by the way, entire length is important, not just a little bit, the entire length. The sheaths are enlarged. You can, maybe you can see, but you'll see it in another image, a protrusion of the optic disc. This is normal. Okay. And this is a high-res, heavily T2 weighted image. And again, you can see the tortuosity. So there's your tortuosity of the optic nerve. The sheaths are enlarged. There's bulging of the optic disc. This is basically those indirect markers that I was telling you. Ventricles are fine. Somehow the CSF is trying to make space into wherever it can, wherever it finds, you know, weak, less resistant pathways. And that is why this patient has this. Basically, there is ischemia of the optic disc, and therefore she has visual loss. And in fact, this patient went ahead. Hold on. Why don't I have what I wanted to show? Okay, probably I have it later. This patient went in to do lumbar puncture. That's the gold standard for the diagnosis of IIH. And the lumbar puncture with the manometer came out to be 45. The normal is 15 centimeters water. So that was very high. And the only thing you can do in the acute stage is to remove a part of the CSF and therefore reduce the pressure. So see how all the first few slides, the things that I showed you in the first few slides are coming back. It's important to reduce the volume of one space so that everything else is working properly. Okay. All right. So, well, I've already given you the diagnosis, so we can go to the next. And because of the knowledge that I had prior to this, we did actually a second MR and studied the veins. And if you look at the superior sagittal sinus veins in a normal subject, you will see that this patient definitely had a lot of venous blood. So the volume, the increase in volume inside her brain was because of the venous blood that was basically stagnant. It was not able to flow out. And so that volume is increasing the pressure, the intracranial pressure. In fact, in these cases, what happens is so there you go. This is the lumbar puncture that I was talking to you about. And in IIH, there we have a theory that, or even a treatment that veins can be enlarged by putting a stent probably, so that there is, you know, you can encourage good venous outflow, even though we don't know what is causing IIH in this patient. It's either hormonal or it's thoracic pressure that has been increased, or abdominal pressure on the vena cava that has increased because of obesity. We don't understand, and therefore it is IIH. But you know, you look at the different compartments and you understand that there might be a problem. There might be some other way of relieving the pressure within the brain. In fact, one of the other things that people do is the DVP is, how do you call it in English? Basically, you put a catheter in the ventricles to remove the CSF. And in fact, in IIH, you have what is called the modified Dandy criteria. And in the modified Dandy criteria, there is abnormal optic nerve sheath with filled out CSF spaces and venous sinus stenosis or collapse, right? This is another patient with IIH, and this is a kid. This is a male 25-year-old, so there is nothing to do with female hormones here. And because of the knowledge that I had, what I did is I ran a venous study, phase contrast venous study. And this has basically a completely disrupted venous anatomy. And this was because this patient has a hematological disease, and he was continuously forming thrombosis in the intracranial veins. And this is the angiogram, and you can see that there is no superior sagittal sinus, for example, and even the inferior sagittal sinus is not visible because of thrombosis. And look at the transverse sinuses. Very, very quickly, this is something very dear to me, the perivascular spaces, and therefore we'll talk about the white matter hyperintensities as well. So these are your perivascular spaces, like little dots in the centrum semiovale and linear in the basal ganglia, and the white matter hyperintensities are positive, hyperintense and flare. Many times they coexist. All right, so you see these perivascular spaces, and around them you have this white matter hyperintensity. Okay, and there's a theory behind this, and I'll show you that. So the perivascular space basically is a conduit for interstitial fluid that carries waste products, for example. So these are the spaces that right now in neurology and neuroscience are being actively pursued, because we really want to understand what is inside the ISF. And if these paths are blocked because of atherosclerosis or other diseases of the arterial wall, then then that might be causing Alzheimer's or other diseases, or other dementia kind of diseases. So just giving you a very quick visual, so that, because we can't talk of everything right now. I'm going to go, this is again another visual which shows you the density of vessels in the gray matter with respect to white matter. There are a lot of vessels in the gray matter, and all around them there are perivascular spaces. The perivascular spaces, if you look hard on your MRIs, you will see that they're always present in the white matter and not in the gray matter, even though the density of arteries are more in the gray matter. Okay, so again, here there is a correlation between the number of perivascular spaces and dementia and atherosclerosis. All right, this is again, probably we'll do another lecture on this, but just focus and look at them. It's not time to report them, but look at them again. This is an indirect marker of something. PVSs are not in the GM. This is a perivascular space around a lenticulostriate artery. Look at that. So this is a space that is directly in communication with the cisternal space. But the ones in the centrum semiovale, these are not directly connected to the subarachnoid space. Little hard to understand, but this is the fact. And these spaces can, in pathological cases, be present everywhere. And again, as you see, the abrupt the distinctions, how these spaces, they abruptly end at the gray matter. Okay. They might even have a different shape. Why am I talking about perivascular spaces? Because the ISF, the interstitial fluid, if it's blocked, the space will basically enlarge, and these are considered a marker of blocked drainage. This is not directly related to hypertension. This is related to the movement of neurofluids, which is all part of pressure changes within the brain. For example, this is a patient with bilateral obstruction of foramen of Monro. And as you can see, she developed an obstructive hydrocephalus, very simple, transependymal transudation edema, very simple. And you can see that some of the perivascular spaces have enlarged here. So there is a difference. There is something going on with the movement. And when you have dilated perivascular spaces, you might in the vicinity have white matter hyperintensity, as I showed you. And that basically means that this area is because of hypoxic, hypercapnic, some kind of stagnant CSF, ISF, which is causing this white matter hyperintensities that is visible in the MR. And mind you, many times we don't see it on MRI because of the resolution. We can't see micro changes unless we do some fancy DTI imaging. So again, look at the perivascular spaces and the white matter hyperintensities. So again, a lot of causes of an increased ICP. All of this you now understand. I'm not going through this, but remember to look at the brain as a whole, okay? Not as just one thing. This is something I'll go very, very quickly, really less than 5 minutes. And this is basically what has been discovered. And I really want you all to understand that this is an important piece, addition to our neuroscience, neurophysiology. So basically what this video is going to show you is that if I inject a tracer in the cisternal space, over time, this tracer will move along the arterioles in the subarachnoid space, in the perivascular space, and enter the brain parenchyma, and doing so washes out metabolic waste from the brain parenchyma, which goes out through the paravenous spaces. So this is your green arrow, green flicking out the amyloid from the brain. This is very simplistic. Science has moved out and beyond this. This is 2012. There's a lot more addition to this. We're not going to go through that. But again, remember that there is a fluid that is moving, which is not visible to our static MR images. This is a study in which the Norwegian group injected gadolinium in the intrathecal space in the lumbar spine, and over time, 1 to 2 hours, 6 to 9 hours, 24 hours, what you're seeing is that gadolinium is actually entering the brain from the subarachnoid space into the gray matter and then in the white matter. So it's actually entering in a centripetal direction. The red is higher concentration with respect to blue. You can see it in the scale. So this is very interesting, that what is in the CSF actually enters the brain. And remember also that these green lines and dots, these are the meningeal lymphatics. They are basically lining the sinuses, the venous sinus lymphatics. It seems that they are draining into the cervical lymph. So in this drawing here, you can see the pre-meningeal channels. So that is also part of the fluids in the brain. And as you can see, the CSF, as I said, has different pathways of absorption, subarachnoid granulations, but also the meningeal lymphatics and towards the brain parenchyma. Questions before I get you to the diagnosis of this patient, or are you just very curious on knowing the diagnosis? Okay.
Speak up.
Okay. Okay, let me finish this little example then. So this is your example, and probably now you'll be able to see the protrusion of the optic nerves and the dilation of the optic sheaths. Okay, this is such an important marker. And when it's a child, you'd have no idea if the child has headaches. You have no idea if the child has visual loss. So this child went into an ophthalmological examination, found retinal hemorrhages. And again, because of the prior knowledge, this patient sedated. Immediately, I went ahead and studied the venous system. And this is his venogram. So stenosis, part of the jugular veins doesn't work, got a lumbar puncture, 48. Again, normal is 15. So now he's in treatment for hypertension. Hopefully, hypertension will be resolved and this kid will not have autism. But this is not something. So that's basically what I have for you here. Most of the time, you don't really image hypertension. You'll image a tumor, you'll image malformation, but if you look at all the indirect signs, maybe those are the ones that are actually the cause of the symptoms that the patient is complaining about. Thank you.